If you're getting ready for the PEBC qualifying exam, you already know how critical the CNS topics are. So, in this explainer, we are going to do a deep dive into schizophrenia and all those related psychotic disorders. We'll be breaking down everything you need to know. So, here's our game plan. We'll kick things off with the spectrum of these disorders, then walk through diagnosis and the main goals of therapy. After that, we'll get into the real nitty-gritty, the pharmacology of antipsychotics, how to manage their side effects, and finally, we'll wrap up by looking at special populations, like pregnancy and patients with comorbid substance use. Okay, let's jump right in. All right, first things first. Let's build a solid foundation. You see, understanding how these different disorders are classified is absolutely the first step. You can't pick the right therapy if you don't know exactly what you're treating. So, at its very core, what is psychosis? It's a loss of contact with reality. And clinically, it helps a ton to think about the symptoms in four main buckets. You've got your positive symptoms, like hallucinations, negative symptoms, like social withdrawal, cognitive issues, and mood symptoms, like anxiety. Being able to spot which cluster you're seeing is key for diagnosis and for figuring out if a treatment is actually working. Okay, now this slide, this is where things get really interesting because it lays out the differential diagnoses. And for your exam, listen up. The most crucial point here is duration. It's all about the timeline. Just look at it. A brief psychotic disorder is less than 1 month. Schizophreniform disorder is that middle ground, 1 to 6 months. And to diagnose schizophrenia, you need signs of the illness for at least 6 months. Then you have schizoaffective disorder, which is kind of unique, right? It's psychosis mixed with a major mood episode that's hanging around for more than half the time. Trust me, these timeframes are pure high-yield facts. Now let's see how these classifications actually fit into the whole diagnostic process, for both clinicians and pharmacists. Really getting this part is vital because an early, accurate assessment can completely change a patient's long-term future. Before a full-blown psychotic episode hits, there's often this prodromal phase. And the symptoms here, things like less motivation, pulling away from friends, just a general slide in functioning, they can be really subtle. It's so easy to mistake them for something else. So as pharmacists, just being aware of these early warning signs is huge, because the earlier we intervene, the better the outcome. So when a patient shows up with a first episode of psychosis, a really thorough workup is non-negotiable. We're not just trying to confirm psychosis, we're trying to rule everything else out. That means a deep dive into their history, a full physical exam, and a whole panel of labs, with CBC, liver function tests, TSH, and of course a urine drug screen to check for substance-induced psychosis. And here's the critical part. We need baseline fasting glucose and lipids before we even think about starting an antipsychotic. That baseline is going to be our guide for monitoring all those metabolic side effects we'll talk about later. This slide just perfectly captures the pharmacist's role in long-term care. We're constantly monitoring. We track psychopathology with scales like the PANS, that's the positive and negative syndrome scale, and how they're functioning overall with tools like SOFAs. We're also on the lookout for extrapyramidal side effects and, of course, those metabolic numbers. And notice the timing. Weight and BMI get checked a lot right after starting a new drug, while fasting glucose and lipids are done at baseline, 12 weeks, and then once a year. This kind of proactive monitoring, that's our job. Okay, here is a fantastic clinical pearl, the kind of thing that just screams exam question. It can be so hard to tell if a patient's apathy and lack of motivation are negative symptoms of schizophrenia or if they're actually signs of a co-occurring major depression. That's where the Calgary Depression Scale, or CDSS, comes in. It's designed for exactly this. A score of 6 or higher is your magic number. It's the cutoff that suggests a clinically significant depression that probably needs its own treatment, like an antidepressant. Okay, so we know how to diagnose and monitor, but what are we actually trying to do with treatment? Let's be clear, the goals here are way bigger than just getting rid of psychosis. At the end of the day, the real goal is functional recovery. Yeah, of course, we want to get all those symptom domains, positive, negative, cognitive, and mood, into remission. But we're also trying to prevent relapse, cut down the risk of suicide and metabolic syndrome, tackle substance abuse, and really help the patient get back into their life. It's a truly holistic approach that's all about long-term quality of life. In the middle of an acute psychotic episode, before we even touch the prescription pad, these non-drug steps are absolutely essential. Priority number 1 is safety, for the patient and for everyone else, and that might mean a hospital stay. The goal is to create a calm, low-stress space, and even when the patient is really unwell, building that rapport, that therapeutic alliance, is what sets the stage for successful treatment and adherence down the road. And that brings us right to the heart of our role as pharmacists, the medications themselves. Let's really break down the different classes and figure out how to choose between them. So, speaking broadly, we've got two main classes. The first generation or typical antipsychotics are really potent dopamine D2 receptor blockers. This is great for positive symptoms, but it also comes with a high risk of movement disorders, what we call EPS, and high prolactin levels. Then you have the second generation or atypical antipsychotics. Their mechanism is a bit more complex. They hit serotonin 5-HT2A receptors along with the D2 receptors. This usually means a lower risk of EPS, which is why they're first line. But they've got their own issues, namely a higher risk of metabolic side effects like weight gain and diabetes. If you can understand these receptor profiles, you can predict a drug's side effects. It's that simple. D2 blockade gives us the antipsychotic effect, but it's also what causes EPS. Blocking the histamine H1 receptor, that leads to sedation and weight gain. Think olanzapine. Muscarinic M1 blockade, you get those anticholinergic effects. And alpha-1 blockade is what causes that drop in blood pressure when you stand up. Knowing these connections is just fundamental for tailoring therapy and counseling your patients. This algorithm is basically our roadmap. We start with a second-gen antipsychotic, titrate it up over a week or two, and give it a fair shot for about 4 to 8 weeks. If it works, great, we continue. If not, we switch to another SGA. Now, if a patient fails 2 different antipsychotics, that's when we call it treatment-resistant, and the clear choice is clozapine. And look at those little side branches. If non-adherence or substance abuse is a problem, a long-acting injectable is a really strong recommendation. Okay, let's talk about long-acting injectables, or LAIs. The guidelines are crystal clear on this. They should be offered as an option to every single patient, even right after a first episode. They're not just a last resort. And the evidence for this is it's powerful. They seriously cut down on relapse and hospitalization rates. But here's the wild part. Their use in Canada is incredibly low. As the next generation of practitioners, this is a huge area where we can improve practice and really advocate for our patients. So what happens when a patient just doesn't respond? Well, we have a specific definition for that: treatment-resistant schizophrenia. It means a patient has failed to respond to at least 2 good trials of different antipsychotics. And in that situation, there's really only one evidence-based option: clozapine. It works better than anything else, and it's the only drug shown to reduce suicide risk. But its use is limited because of the risk of really serious side effects like agranulocytosis, which means patients need strict blood monitoring. Okay, let's shift gears to something that is so critical for us as pharmacists: managing side effects. Adherence is so often driven by how well a patient tolerates their meds, and this is where we can make a massive difference. This chart is an absolutely priceless clinical tool. You can see the relative risks for each drug at a glance. For instance, olanzapine and clozapine, they carry the highest risk for weight gain and metabolic problems. Risperidone and polyperidone, they're the biggest culprits for high prolactin. Then you've got aripiprazole and brexpiprazole, which tend to be better metabolically, but can cause that awful restlessness we call akathisia. Using a table like this helps you really personalize the choice of drug based on a patient's own health and risk factors. Knowing how to manage acute EPS is a must-know. For an acute dystonic reaction, that terrifying muscle spasm, the treatment is immediate: an intramuscular anticholinergic like benztropine or diphenhydramine. For akathisia, that intense can't-sit-still feeling, beta blockers like propranolol are first line. And for drug-induced Parkinsonism, the very first step should always be trying to lower the antipsychotic dose. You only turn to oral anticholinergics if that doesn't work, and we never use anticholinergics just to prevent these things from happening. When it comes to metabolic side effects, the name of the game is being proactive. Prevention starts on day 1 with counseling about diet and exercise. We monitor like a hawk, and if a patient's weight goes up by more than 7% from where they started, that's our cue to take action. That could mean starting a formal behavioral program, thinking about a switch to a more metabolically friendly drug like lurasidone or ziprasidone, or maybe even adding metformin to help with the weight gain. Okay, let's try a quick case. A patient on risperidone develops galactorrhea. What is going on here? Well, this is a textbook case of hyperprolactinemia. Risperidone's powerful D2 blockade in a specific brain pathway jacks up prolactin levels. So, what's the fix? You switch to a prolactin-sparing agent, something like aripiprazole or quetiapine. And finally, let's touch on some really important things to keep in mind for specific patient groups and common co-occurring conditions, because therapy is never, ever one size fits all. Treating psychosis during pregnancy is all about a careful risk-benefit talk. But here's the bottom line. The risk of having a psychotic relapse during pregnancy, which can lead to all sorts of problems like poor nutrition, stress, no prenatal care, that risk is usually much greater than the risk from the medication itself. So for most patients, the recommendation is to continue their antipsychotic at the lowest dose that keeps them well. The postpartum period is an extremely vulnerable time. The risk of relapse just skyrockets, up to 24% in those first 3 months. This is basically a psychiatric emergency. If a patient stopped their antipsychotics during pregnancy, they need to be restarted immediately after they deliver. Now, for breastfeeding, the data is a little more sparse. But based on what we do know, olanzapine is generally considered the preferred second-generation antipsychotic because not much of it seems to get to the infant. On the flip side, breastfeeding is a no-go for patients on clozapine. And in every single case where a mother is on an antipsychotic, the baby has to be watched very closely for any side effects, like being too sleepy or not feeding well. We simply cannot talk about schizophrenia without talking about comorbid substance use. The numbers are just staggering. Cannabis use in early psychosis can be as high as 86%. And just look at smoking. 70% of patients with schizophrenia in Canada smoke. Compare that to just 20% of the general population. This has huge implications for their physical health and, of course, their treatment. And this perfectly highlights a critical drug interaction. It's not the nicotine, by the way. It's the other junk in cigarette smoke. These things called polycyclic aromatic hydrocarbons are potent inducers of a liver enzyme called CYP1A2. And guess what? That's the enzyme that metabolizes both clozapine and olanzapine. So what does this mean clinically? It means a patient who smokes is going to need a much higher dose of these drugs to get the same effect. And if they get admitted to the hospital and suddenly stop smoking, their drug levels can shoot up to toxic concentrations, so you'd have to cut their dose.
So let's end with this question to think about. We've got the evidence for early intervention. We have better tools like LAIs. So what's the single biggest barrier we still have to overcome to help patients achieve long-term recovery? Is it stigma? Is it access to care? Is it the side effects of medications? As future pharmacists, figuring out the answer to that question is really the key to moving care forward. Thanks so much for joining this explainer.